We are talking about dementia. And as Dr. Ansis says, people with Down syndrome are most likely to have Alzheimer's. And there are other types of dementia that are out there. But I think the main thing that I want to say here is that dementia, it's a group of behavior and symptoms that are caused by different conditions or diseases. Um, so it's an umbrella term that can also mimic other types of diseases or medical issues that might be happening to an individual. Somebody may have had a stroke. Somebody may have started new medications, and these medication side effects could be mimic itself, and people might think, "Oh my gosh, my family member has dementia." But it's to look at all the different things of medical that need to be ruled out before that diagnosis of dementia comes in. So don't jump to that immediately. If somebody is dehydrated, if somebody has a urinary tract infection, many folks with Down syndrome have hypothyroidism, and that hypothyroidism also has the same effects of dementia. Somebody may be really tired, they're not thinking, they might be more cranky. So getting that blood test just to make sure that the thyroid is within its system. Somebody could have cardiovascular disease, environmental issues that could be happening. You know, maybe there's a gas leak that's out there and that's causing somebody not to feel all that great. Sensory impairments, somebody with depression also can mimic some of the symptoms that you will see for a person with Alzheimer's. Dehydration, and as Dr. Ansis said earlier, or it might have been Brittany who was talking about sleep apnea, also very prevalent in people with Down syndrome. Um, Also, I think many folks with Down syndrome may have a vision loss, impairment, a hearing loss, osteoarthritis, and all of those conditions can also affect how somebody is moving in their day-to-day life, even if they have been diagnosed with Alzheimer's, to keep an eye on those different things to make sure that people are hydrated and they're having good nutrition. Vitamin B12 is also another area that can have symptoms. Not going to really go through this because Dr. Anses did, but the loss of brain cells affect abilities for us to be able to plan, for executive functioning, controlling our mood, our taste, and processing language. So the brain helps us do all those things. And as that brain is affected, those different skills and or abilities that people have can be affected by that. So we have normal age-related memory versus dementia, because, you know, sometimes we our aging just kind of causes us to have a little memory loss, but we're able to provide examples of, you know, I lost my keys and I remember I lost my keys and I remember I found my keys and I know where they are. Where somebody with dementia may not be able to necessarily, they know they lost their keys, but then later they just forget they lost their keys and they don't go backwards on that. Occasional searching for words, where somebody with dementia is going to have more frequent word finding that they need support on. Pausing to remember directions, but you're not really getting lost. And sometimes, well, people with dementia will get lost in familiar places. Remembering recent events, whereas people with dementia are going to remember those long-term events that have transpired rather than what's something that happened yesterday. Remembers our interpersonal skills at the same level, whereas people with dementia will lose that whole interest of being involved in social activities and being involved in things that they used to really enjoy. So, point here is don't assume when you see any symptoms that the person has or has Alzheimer's. You want to always make sure that you're ruling out any medical causes that can then be reversed of what you're seeing, using a neurology specialist. Dr. Ansis is a great person to see. And if not, I'm sure that he would give a referral, but it sounds like he's taking new people in. Use an established assessment. So they say it's good practice for people with Down syndrome to do a baseline of where somebody is between 35 and 40. So before there's any symptoms that you're seeing or changes that you're seeing with an individual, you should want to really have that baseline in place. There's a couple of different baselines that are out there. Um, Alzheimer's Association has a cognitive screening and assessment, NTG, which I spoke of earlier, as well as Dr. ANSYS. So it's National Task Group on Dementia for people with intellectual and developmental disability. They have an early detection screen for dementia, which I'm just going to give you a quick show of what that looks like. So you can fill it out online. It's looking at medical, what's happening with the individual. And as time goes, you'll have it, the current health status and then how that compares to a year ago. But when you do your first one, it's your first one. So you're going to get that baseline, looking at vision impairment, hearing impairments, so all the different medical pieces to put up there to see if there's changes. And then it will look at activities of daily living, whether it's always been the case, always, but now it's worse, or it's a new symptom in the last year, or it's just something that doesn't apply. So it's just to get a baseline of where your family member is before there's any other change that might be occurring.
Marianne, is that something a family can complete on their own, or do they need to go to a
Absolutely.
physician?
This is definitely something that you can fill out on your own. It is by observation that what you're seeing, language does not initiate conversation, does not find words, does not follow simple instructions. You're going to know the answer to these where a clinician won't because they don't have that familiarity with your family member. So absolutely. And there's also another thing that you can do. It's an informal collection where you're looking at what your family member has done over the years and looking at a baseline description of abilities. So this is another thing that I will give you this. This is from the, let's see, the National Down Syndrome Society. But it's really looking at what is happening now. What is the function of your family member? How independent is your family member in performing self-care tasks and with bathing, dressing, grooming, eating, and walking, so that you have this baseline that says this is what's happening. The same thing with skills. What academic skills have been achieved, chores or responsibilities that the individual performs around the house, jobs that the individual has had, and activities that he or she do at during the day, or if they're in a day program, and their talents and abilities throughout lifetimes, so that you have that history of what's happening with your family member before there's anything else that even seems to have been a change. It gets down into memory, behavior, language, personality, and mood. This is another one that I just don't think does not helpful for a person with Down syndrome necessarily. It's a simple one and it's from Washington University Dementia Screening Test. So it's just options that are out there. So the different stages of Alzheimer's, we have generally three stages. The early stage where you're going to see confusion and some memory loss, disorientation in space of where they are now, and that they're in the living room, kind of just figuring out where they are with space. I have a hard time with that one. I don't know why. And maybe Dr. Ansis can talk about that later. Problems with routine tasks and needing reminders, where in the past they had the routines and they didn't need any support. So now they're just needing just a little bit of reminders. You might see a little bit of personality change. And maybe even, maybe less interest in some of the things that they used to do or that they're used to doing. Middle stage, people are starting to have more difficulty with activities of daily living, whether that's their hygiene, showering, brushing their teeth, doing things around the household that, they used to be able to, take that trash out every evening, or taking the trash cart out to the street. And those were just things that they automatically did. But now you're seeing a change that routine that they followed, it just can't seem to do it as they did in the past. Maybe there's some anxiety, or paranoia or agitation. When you're starting to get more confused, it's natural to have some of that anxiety and paranoia because you can't even always express what it is happening. And I don't care if it's a person with a disability or without a disability, you're going to see that because it's a change that you don't understand of what's happening. There could be sleep difficulties beyond just the sleep apnea, but just not maybe falling to sleep. So, having a good sleep hygiene in place and routine that you follow could be helpful. Could be difficulty in recognizing familiar people and their names. Maybe starting to wander just a little bit, and maybe there's some restlessness. Just can't seem to get settled and always want to be doing something, but yet they're not sure what to do. Getting lost in familiar places. It could be as easy as I don't remember where the bathroom is. Where's their bedroom? And sometimes having some signage on those different rooms might be helpful, where it's just a picture of the individual outside their bedroom so they know where they're going. And same thing, for the restroom, it could just be a picture of a sink, or a toilet. Um, Also, there can be an onset of seizures where your family member with dementia didn't used to have seizures. Now they do, or they've had seizures in the past, and now you're seeing an increase of the time that happens. There also could be starting with some incontinence, whether it's incontinence of urine or incontinence of bowel. And then the late stage, you're seeing a loss of speech, inability to be able to process necessarily what someone is saying. Their appetite isn't the same. The whole total loss of bladder and bowel, mobility, the individual's not walking anymore, total dependence and needs that support. I'd say also in that middle stage, you will sometimes see where there is a change of mobility. Some of the folks that I supported who were going up and down the steps were doing, even in the early stage, did fine. Once they hit that middle stage, there was problems of going up and down the steps and some lack of stability when walking and needing more support with walking up that curb or holding on to the rail when going upstairs and needing some real prompting there. This is a video which I'm not going to show because I don't think that we have time. But it is also, I think it'll be in the deck that will be out there. And we'll make sure that there's either a link. And what this video shows is Derek in his environment and what is happening in the environment and how he's responding to that. So, for instance, if the lighting in the room isn't light enough, maybe there's shadows that are coming in from outside, that could make someone think that, oh, there's a monster here. There's something here that I don't know what it is, and it's frightening me. Lighting also so that when you're walking, you can see where you're going. And getting rid of those throw rugs and carpets can also help to prevent falls. Sometimes marking the stairs with a bright color so that the individual sees that there's a step up. Could be like one of those reflecting pieces of tape. Railings or reflective tape, also could use it on railings if it's needed. Using bright colors. makes everything brighter. When you have bright things, you feel better. Also, they're easier for people to see. Adding graphics to help people identify, as I was talking before, of identifying where their bedroom is. Is there some kind of graphic so they know where to put things away? Following your person and knowing what they used to do. And sometimes if there's a picture there or words, that might be helpful for them to figure out what it is that they're doing. Be aware of depth perception issues, and modify services with contrasting colors. So for instance, so that depth perception of walking up that curb can be difficult, or even going from a threshold from one type of flooring to another type of flooring can be difficult. Now, my brother has issues, even if it's just like going from sidewalk to blacktop can be very hard. And people with dementia often see black as being a hole, so that could be frightening for them. Um, Another example of modifying surfaces with contrasting colors. So if you have a table and the table is white, and you have a white plate on the table, and then there's some food that's on the plate. One, people with dementia don't always seeing white is sometimes just not there, it's just kind of floating. So having a contrasting color for a white, say you could put a placemat down on the table and then put a plate of a different color on there, so that if it's white plate and you put mashed potatoes on it, they may not see that mashed potatoes or see the rice that's on the table on the plate. So having different colored plates also can be supportive, so that they really see what's there in front of them. Assessing any kind of safety needs and removing any obstacles for safety, as I was talking about before, the throw rugs that are out there, and making sure that there's not, a lot of clutter that's around where it can be difficult for people to get around because they're just not seeing it where they used to. Change in type of support, knowing what support is needed, where your family member may have been just doing really great and now they need more support. And maybe it's just some prompting of brushing the teeth, whereas before they were doing it independently. And also, that prompt of if you're asking someone to stand up, they may not get that. So it's also having them, you can mimic what you want them to do, so they understand, maybe it's gonna brush your teeth, gonna pick up the toothbrush, and then you're gonna put on the toothpaste. One piece of information at a time, so someone is not getting overwhelmed and they can follow what you are talking about, what you want them to do. Getting out and having opportunities to walk around in safe areas is really good, because activity is also very important for the person. Emphasizing abilities and helping and working with individuals to focus on the skills that they have, and those skills that can affect dignity. So, if we have someone who is incontinent, in making sure that we have, the Depends that someone can put on so that their clothing is not wet. So maintaining someone's dignity, making sure that they look nice, and having them focus on those skills as well. And things that they might be doing around the house are things that are of purpose. So someone helping to fold towels or matching socks. Those all have purpose of why you're doing those, and they're just not things to do because you've made them up, but they have purpose because you're going to wear those socks and you want them to look the same on each foot. Communication, also very important. You want to make sure that you're using patience because you can get stressed out because you are supporting someone differently than what the things in which they used to be able to do and figuring out how to best support them. Breathe. And also remember giving direction, one-step directions, according to what they're able to do at that point in time, so that they understand what your expectation is. Keep verbal requests simple. Control the volume of your voice so that when, let's say somebody spilled a glass of milk, as parents, we stop, oh my God, you spilled that milk. What are we going to do? Blah, blah, blah. But in this essence, what we want to do is step back. It's just a glass of milk. Take that deep breath. It's okay. We'll just clean it up and move on to the next thing. We'll get you something else to drink. Developing communication adaptations to help the person know important information. So changing words, using pictures, showing them what it is that you want them to do or what you want them, hoping that they're going to understand. If figure out how to make those adaptations to meet where your family member is. Visual cues are helpful, sometimes pointing. Talking with our hands can be helpful to individuals. When Leave It to Beaver is over, then we're going to eat dinner. So that's giving that association of what's happening. Speaking in statements, rather than asking, what do you want for lunch? You can say, we're going to have, what are we gonna have? I'm gonna say SpaghettiOs. Not a good example, not a nutritional thought, but SpaghettiOs came to mind. Somebody was just talking about that to me yesterday. So do you want SpaghettiOs? Or let's go into the kitchen, we're going to eat lunch. And then you can ask, but don't want to put too many choices out there, but asking and directing what it is that you're guiding them to, but yet get their input. So communicating with the person with Alzheimer's, do not explain too much or ask if they want to, because the answer oftentimes is going to be no. So that's where we are giving more direction. Guide them to the steps that need to take place. So let's say that you're going to do an art project. Sometimes having that art project already, having everything out already, the paint, the water, whether they're using blank paper or if they're painting something else that's a picture, having those out already so that the person isn't waiting and you're ready to jump right in when you get over to do that art project. Use one-step instructions, be calm, keep simple, verbal, gestural, and written cues. It's not helpful to try to convince a person with dementia of reality because they have their own reality and they cannot step out of it. And we have to jump into their world because they can't jump into ours. So sometimes we have to just embrace that therapeutic truth. Sometimes if we've said something that has upset them, even though it may have been factual, and apologize because something made them feel bad. And we can still apologize even if that wasn't the intent or they misunderstood. Another example of giving guidance is, here's your medicine. Do you want water or juice? So don't give more than, I guess, two different choices out there can make it easier. And sometimes it might just be, do you want your pills with water? So we're entering their world. You want to provide some structure and routine can be very helpful. Changes in environment and daily routine, you want to keep those to a minimum because it can make the person very confused. Giving choices of two or diminishing two choices. So it could be one choice, it could be two things, but I wouldn't do more than that, but follow what the person, how they are responding to what it is that you are bringing to them. Set up a routine and stick to it. Sometimes the more steps there is to learn something, the harder it is, and they may not be able to get it. So one step at a time, keep things simple. And simplify those routines to reduce choices, to minimize feelings of anxiety. Allow time for processing. So when you give information to your family member, just give them time to respond. So here's an example of a daily plan. So in the morning, you can have this set up, you know exactly what's going to happen. You're going to work with the individual with their morning hygiene, washing their face, brushing their teeth, taking a shower, whenever that shower happens, whether it's in the morning or the evening, wherever it's set, kind of keeping it there, preparing and eating breakfast. And there can be some support that they might be able to do in helping prepare that breakfast. It could be just pushing the thing down to make toast. It could be getting the forks out of the drawer to put them on the table, but getting them involved in the process. Maybe later on, you're just going to have tea and you're going to have a little conversation about the weather, or the day. And that day could be, this is what's going to happen. Um, that we're going to fold laundry and we're going to do some other chores. We're going to take a break. Then we're going to have lunch. So being able to identify what's happening when and next. If it's helpful for the individual, you can also put those in picture form. So they're going to do fold laundry or try a craft project or reminisce over old photos. Could take a break and have a little quiet time because sometimes too much activity that people need to kind of just chill back. Maybe you're going to do chores together or take a walk, play an active game or do an art project. So remember, still getting that physical activity is really important. It's important for the brain, it's important for the body, and it also helps sleep. Afternoon, prepping lunch, listening to music, or looking at photos, or maybe there's a special TV program they prefer to watch or videos that they have. So setting up your day so that you know what's going to happen. And if you have somebody else who's coming in to support you and your family member, so it's that um, care partner who might be coming in would also have an idea of what should be happening that helps create that routine and maintain a routine. Sometimes there's some little changes, but for the most part, um, there's always something that's happening of two or three different things that could be happening in that afternoon sequence. And then the same for the evening. I'm going to keep going. So how to support a person with Alzheimer's. Do exercise, aerobic, and getting that heart going is really helpful. Scrapbooking and photos. So it's another thing that you can do when you're at that 35, when the individual's 35 and you're doing some assessments. Start doing some scrapbooking and putting those photos together so that when time comes, if it comes, that you have that scrapbook already prepared and you can go in and look at it and talk about the different activities or the different people or the things, places that you have traveled to, that you can talk about those. And that will also be helpful if your family member moves into someplace other than living with you into receiving residential support somewhere, that's really helpful to the support staff because then it helps them understand what the individual's past is as well. Revising individual schedules to reflect new preferences because some of those same interests that that your family member may have had, that might be changing. It may not always stay the same. Doing word puzzles, crafts, memory box, pull something out of a memory box and talk about it. or a story about something if it's just a vintage item that's coming out and something to talk about. Playing music from their generation. Music is such a big thing because sometimes people don't always remember what's happening, but man, you put that music on and they're going to sing it and they're going to sing it word for word, and it brings so much joy. Don't ignore, don't talk. We call it, no baby talk. Assume that they are confused. Do not quiz and say, "Do you remember my name?" With my dad, it was always, he would call me kiddo. Kiddo was good enough. Whether he knew my name or not, I don't know because I didn't ask. But it can make someone feel really bad if they don't have long-term, don't do anything that's going to have a long-term consequence because they're not necessarily going to remember that this is the consequence. Um, Attempt to reorientate. So we're going with where the individual is in their lifespan and what they're thinking of. So staying in their world, don't reorientate or don't argue with, because the person with dementia is always going to win because that is their reality. Don't just sit and do nothing because that causes a lot of boredom and also can cause some um, maybe some more challenging behaviors because they don't know what else to do. Um, I don't know how much time you want for questions because we are approaching the 8 o'clock hour, but there's one other thing that I want to talk about. That's on a different piece of paper. So when you see some challenging behaviors, there's a kind of a three-step approach that you can take. Examine the behavior. What was it? Was it harmful? Did something trigger it? Could something be causing the individual pain? So remember those things that sometimes if a person is really tired, if they have pain, it can cause them to act out in a certain way because they don't have the words to say that I hurt. Could this be related to medications or illnesses? Explore what some solutions are and try different responses. We know that sometimes making a change will work. And one thing that you do one day may work, and then on the next day it may not. But then the next day it may again. So always going back to that. Looking at physical pain or discomfort that could be causing a challenge for the individual. Overstimulation, there's too much noise or the environment is just too overwhelming. That could cause that. Unfamiliar surroundings, being in new places, or the inability to recognize their home. Um, I know a lot of folks that I supported, they got to the point where they did not want to go out and they wanted to stay home because that's where they were comfortable. My dad at one point was like, "I just want to go home." I'm not sure where that home was, but it wasn't where we were. Complicated task. It could, if they're frustrated, that can also cause some challenges with behaviors. So difficulty with activities and chores can cause frustration. So this activity, so that's kind of where I wanted to go with that. And what you do to work with the individual trying to re-engage or to move them in an environment that is more quiet can be helpful. Getting Tylenol for or whatever they have for maybe they have arthritis. How do we negate what is happening that's causing that challenge to occur? Pleasurable activities, sometimes connected with something that's more stressful, can also be helpful. So this toolkit is out there. It gives you lots of different activities that you could do. We'll put it in there as well. Just remember, you're the expert. Use trial and error, be creative. See what works for you and for your loved one. What works one day may not work another, but keep trying and go back to it another day. So a couple of things I kind of want to get to is for you, peaceful, easy feeling. You need time for yourself because if you don't take care of you, you're not able to take care of anyone else. So identifying what brings you pleasure, being around other people, going places, having activities, you getting that physical activity, setting up daily routines and environments that give you that Zen feel, are so important for you to take care of yourself. So that is something that your care partners can help with as well.
All right, and I'm going to close out by saying that this can be challenging if you're just starting to see the things that Marianne was describing. So I want to remind you that we have navigation services at the ARC. Those navigation services could help you set up a weekly routine for your family member. They could help you think through what kind of medical advocacy you might want to work on. As long as you have a goal that you need help to achieve, we can do some short-term navigation support. And thank you again, all three of you, for being such great presenters and sharing so much information with our families. Everybody have a wonderful evening.